Hello and welcome, everybody. My name is Tom Spitznagel, and I'm currently working as a resident doctor at Stadtspital Zürich. In this talk, I would like to present a study that we conducted in collaboration with the University Hospital of Zürich. Let me just share my slides. So I hope that you can see them right now. So in this retrospective analysis, we compared subthreshold microsecond pulse laser and photodynamic therapy in the treatment of chronic CSCR. In this presentation, I will briefly review the underlying disease mechanisms, the clinical classification, and the current therapeutic approaches, before focusing then on the mechanisms and practical aspects of half-dose photodynamic therapy and SML, as well the workflow used in our study. I don't have any conflicts of interest. CSCR is a macular disorder predominantly affecting young to middle-aged men. It is characterized by the accumulation of subretinal fluid, leading to blurred vision, metamorphopsia, and reduced contrast sensitivity. Although CSCR has been studied extensively, its pathophysiology remains incompletely understood and is likely multifactorial. One of the leading concepts is choroidal dysfunction, characterized by choroidal thickening, hyperpermeability, and an increased hydrostatic pressure, which then overwhelms the barrier function of the RPE. Another widely accepted theory involves primary RPE dysfunction with impaired fluid transport and focal defects, allowing leakage into the subretinal space. Hormonal factors can also play a central role. Both exogenous corticosteroid use and endogenous hypercortisolism are strongly associated with CSCR, suggesting dysregulation at the level of the choroid. In addition, autonomic imbalance and stress, or like stress-related sympathetic overactivation, have been proposed as contributing mechanisms. Clinically, CSCR is not a uniform disease entity, but presents with different patterns. Based on disease duration and the structural characteristics, CSCR is commonly classified into an acute and chronic form, and furthermore in a recurrent form. Acute CSCR is defined by the presence of the subretinal fluid for less than 6 months. It typically affects younger adults. It is more often unilateral and is associated with relatively limited RPE alterations and a more favorable visual outcome. In contrast, the chronic CSCR is characterized by persistent subretinal fluid lasting for longer than 6 months. These cases more frequently show like complex disease patterns with widespread RPE changes, higher rates of bilaterality, and a significantly worse visual prognosis. Recurrent CSCR represents an intermediate phenotype where episodes of subretinal fluid reoccur after periods of resolution. Importantly, this recurrent disease may gradually evolve into a chronic form, contributing to cumulative retinal damage, for example, like atrophy, over time. And this distinction between those forms is clinically crucial as the likelihood of spontaneous resolution decreases with disease chronicity, while the need for active intervention increases. The management of CSCR depends on disease duration, severity, and the presence of the subretinal fluid, and of course of structural complications. In acute CSCR, initial management often consists of watchful waiting, depending a bit on the hospital, on the doctor. Sometimes it's 3 months, sometimes it's maybe 6 months or something in between. Whenever possible, exogenous corticosteroid therapy should be discontinued or reduced, as steroid exposure represents one of the strongest modifiable risk factors. In cases with persistent or recurrent subretinal fluid, several active treatment options are available. Half-dose or half-fluence photodynamic therapy has emerged as one of the most effective evidence-based treatments. On the other hand, there is like this intravitreal anti-VEGF therapy, but it is generally reserved for cases with a secondary MNV. And it is not indicated for uncomplicated CSCR. Conventional focused laser therapy has largely fallen out of favor in modern CSCR management due to the risk of permanent retinal damage, and it has been replaced by less destructive approaches. Systemic mineralocorticoid receptor antagonists, such as eplerenone, have been investigated as well based on the hormonal pathophysiology of CSCR. And yeah, however, let's say those randomized control trials have shown limited to no benefit over placebo. For example, the Vicky trial. So its role remains controversial. More recently, this more, let's say, non-damaging laser-based approaches, such as the selective retina therapy and subthreshold microsecond pulse laser therapy, have gained increased attention. These modalities aim to stimulate the RPE without inducing visible retinal damage and represent, therefore, attractive alternatives, particularly when PDT is unavailable. Among these options, photodynamic therapy remains the reference standard. Let's talk about a half-dose PDT. Half-dose or half-fluence PDT is currently considered as one of the most effective treatments, as said. The therapy primarily targets the choroidal component of the disease rather than the neurosensory retina. After intravenous administration, Visidyne accumulates preferentially within the choroidal vasculature. Upon activation by laser light, this molecule generates reactive oxygen species that will induce a localized oxidative damage to the vascular endothelial cells, leading to transient choriocapillaris hypoperfusion, vascular remodeling, and reduced choroidal hyperpermeability. As a consequence, hydrostatic pressure beneath the RPE decreases, allowing for resorption of subretinal fluid and restoration of the retinal anatomy. Importantly, the use of reduced dose or reduced fluence PDT limits excessive reactive oxygen species mediated tissue damage, thereby minimizing adverse effects such as RPE atrophy or permanent choroidal ischemia. Unfortunately, there has been a big shortage in the Visidyne, and therefore there is a need for new therapies, for alternative therapies. So let's go on to the subthreshold microsecond pulse laser therapy. It represents a fundamentally different approach, as said. Unlike conventional continuous wave laser treatments, SML delivers energy in very short pulses, thereby avoiding visible retinal damage and preserving the retinal architecture. The exact mechanism of action remains not completely understood. However, it is believed that SML induces a biological response within the RPE rather than causing a thermal destruction. Proposed mechanisms include stimulation of the RPE cell metabolism, restoration of the internal blood-retina barrier, modulation of gene expression involved in wound healing, and upregulation of heat shock proteins. Through these effects, SML may enhance the RPE's ability to actively transport subretinal fluid back into the choroid. While this approach is less invasive, it is repeatable and more widely accessible than PDT. Current evidence remains unsure. So that's why Stadtspital Zürich and the University Hospital of Zürich conducted this retrospective study. Patients treated with either PDT or SML between December 21 and June 23 have been included. They had to be over 18 years of age. They could have acute or chronic CSCR and at least a follow-up of 3 months. A concurrent intravitreal therapy was an exclusion criteria, as well as a secondary MNV. All those patients received either standard half-dose PDT or subthreshold microsecond laser with the Navilas laser system. Treatment parameters were used according to the protocol from Khablani et al. The laser spots were 577 nanometers, measuring 100 micrometers in diameter. The pulse duration was set to 100 milliseconds, and treatment power was 30% of the titrated energy. On the bottom right-hand side, you can already see a glimpse of what it looks like, but I will show you a bit more in a second. Here you see some more insights into the Navilas system. There is this big use case where we can import an overlay, for example, an OCT or an FA. Unlike the conventional laser treatments, this SML allows treatment of the foveal center as no visible retinal damage is induced. So on the left-hand side, you can see this overlay, and the area can be transferred into the Navilas system using this registered OFOS image, the SLO image of the OCT. Or importantly, treatment planning can be performed in advance. The treatment area, the laser parameters, and the spot pattern can be defined and reviewed prior to the actual treatment session, supporting standardized and reproducible laser application. Within the Navilas planning module, the laser treatment area is defined, including spot size, spacing, treatment density, and so on. As you can see here, you can set 2 zones where those are like the danger zones. And then in here, we set or mark the area that is going to be treated automatically by the laser. And on the right-hand side, you can see the executed treatment area with the parameters used. Furthermore, this treatment can be performed either way, with or without a contact lens, depending on clinical preference and patient-specific factors. During the treatment, the planned laser pattern is overlaid onto the live fundus image, enabling this precise and reproducible laser application. Finally, the system is documenting the exact executed treatment area, as I showed you, which is particularly valuable for follow-up and repeated treatments of those patients. We assessed in our study in the OCT the presence of subretinal fluid and as well the BCVA. We did some linear mixed effect models and some generalized estimating equations in the statistics. And let's already go ahead with the results, the baseline characteristics. As you can see, we enrolled 31 eyes in the PDT group and 37 eyes in the SML group. The age was more or less the same. Same goes with the gender. We can see here a difference between the SRF duration prior to PDT, and the BCVA was similar in both groups as well. The subretinal fluid, there was no significant difference between those groups regarding the subretinal fluid. You can see here at baseline, 100% in both groups had subretinal fluid, and then after 3 months, we had 45% with the presence of subretinal fluid in the PDT group, and around something between 70 and 80% in the SML group. After 6 months, we had around 60% and a bit over 70%. Furthermore, we evaluated the BCVA. Same goes here. No statistically significant changes were found. In the beginning, the BCVA was around 0.67. After 3 months, it was already better, 0.83 and 0.74, and more or less the same after 6 months as well. There seems to be a slight difference between VA, but not statistically significant. So, to the conclusions, PDT or SML. We can say that in our data, it was inconclusive which therapy worked better, since there hasn't been any statistically significant result. On the one hand, PDT, it seems to be more effective than SML, indicated by this greater subretinal fluid resorption. There is a positive effect on visual acuity after 3 and 6 months, as said, statistically not significant. And there is this limitation of PDT, first of all, with this availability, with this shortage of the Visodyne, and as well the higher costs. On the other hand, there is this SML. It seemed to be a bit less effective, but it is a viable alternative. Why? There has been as well a positive effect on the visual acuity after 3 and 6 months. It is less invasive. It is cheaper, very easily accessible, and you can do it several times, so it's repeatable. Therefore, there are some practical consequences. In our house, we still do initially watchful waiting, depending on the patient, on the general characteristics, and so on, usually around 3 to 6 months. And then we start with the first SML treatment. If this is insufficient and there is a lack of treatment response, then we switch to half dose photodynamic therapy treatment. Furthermore, there are some limitations to our study. First of all, the retrospective study, the retrospective design of our study, as well as the relatively small cohort. We have some future plans in mind. We are already doing, in fact, a detailed fluid compartment analysis with deep learning with help of the Discovery Retina AI platform. We will include around 6 centers and analyze lots of patients with just chronic CSCR in this software. So thank you very much for your attention. I hope this talk helped to clarify the mechanisms and clinical roles of photodynamic therapy and subthreshold microsecond pulse laser in the management of CSCR. I would also like to thank Katrin Fasler and Sandrine Zweifel, especially, both of them, for their support and supervision of this project from the University Hospital of Zürich side. Thank you very much. Have a nice day and enjoy the other lectures in this winter school.